I thank the chairman and Dr. Woodcock. Thanks very much for being with us today. I'd like to kind of go back to what Dr. Gingrey was talking about at the very end in regards to drug shortages. And I've been working with several other members in the past few months on this issue. And first of all, if you said in your opening statement that, especially on drug shortages, that we had a perfect storm. Could you describe what that perfect storm is or was?
Well, it was the enhanced utilization of the older sterile injectable drugs, okay? So the demand went up for them. At the same time, new sterile injectable drugs went generic. And so then firms took those on as well. So then the demand on their lines, they have a limited number of manufacturing lines that can make sterile injectables, all right? Because it's very hard to do that. So the demand went up both for the existing drugs and the new generic drugs that were sterile injectables. At the same time, it takes a while to expand the capacity and bring up new facilities. So that did not happen. And then manufacturing problems occurred within many of those lines, thus in making them have perhaps to shut down the line and precipitate a sudden shortage. The other manufacturers who might take up the slack were also having capacity problems of their own or having manufacturing problems. So all these factors came together to create really an unprecedented amount of shortages that we're trying to deal with, and shortages of drugs that Americans cannot do without.
Let me ask then, over the past year, what have you all done to alleviate that problem?
In 2011, we alleviated, we think about, 175 drug shortages were alleviated by our actions. Now, 86 of those, I think, were from one firm where we were able to do interventions. But we have multiple interventions, as I described, that we can alleviate those. Nevertheless, there's several hundred shortages that are ongoing.
Are there additional items that you can do then?
Pardon me?
Are there additional items that you could work on to help on that issue?
Yes. Well, since the executive order by the president that asked firms to notify us of any kind of shortage, and we have also put in a database that we are tracking these very carefully. We've added staff to the drug shortage program that we have at FDA, but we do feel that if there were legislation that requested companies or required companies to notify us, that would help us in perhaps averting more shortages.
And also, is there a disease area where there are more significant drug shortages than others?
Right now, we're hearing from the cancer community, and that's because many of the cancer drugs are injectables. But the injectable drug shortage affects many other kinds of disease areas. And over the years, historically, you couldn't predict where the shortages would arise. They have been in all sorts of disease areas.
And also, will the generic drug user fee help with the drug shortage issue, do you believe?
I believe that having a robust industry that has predictable timelines for its applications and can get applications through, and also having an inspectional force that we can get out there quickly and do the inspections in the appropriate time will help with shortages, because one of the things we need for shortages is we need more than one manufacturer that's able to make that drug. So if something happens at one plant, then there's somebody else who can ramp up production.
Okay. And some of the committee hearings and the press have suggested that the key characteristics of the drugs in shortage of older physician-administered drugs underscore a failure in the older generic market, and that incentives in this market are critical to solving the crisis. Do you agree with that assessment?
I'm sorry, could you repeat that?
Yeah, there's been some in the committee hearings and also out in the press have suggested that the key characteristics of drugs in shortage, older physician-administered drugs, underscore a failure in the older generic market, and that incentives in this market are critical to solving that crisis. And do you agree with that assessment?
I I'm not qualified to make a judgment on that. Being a physician and not an economist, the HHS report felt that it was a multiple number of factors, and it wasn't simply an incentives problem. But Teresa, do you have?
Yeah, I think that report would probably provide the best description of all the kinds of factors. A number of them are economic, and factors that are not within our ability to control. And if there may be other ways to address those, but we have limited ability to address those factors.
Okay.
No ability in some cases.
Thank you very much, Mr. Chairman. I see my time has expired, and I yield back.